You drop the screen out, James. Excellent. Well, good morning, everyone, and welcome to another Three Nations Dementia webinar. We're all very happy and pleased to be with you this morning. This morning's theme is hospital care for people with a dementia diagnosis, with an added thing from Keith about how it affects you when a carer goes into hospital. Many admissions into hospital are non-emergency and could be treated at home or in outpatients. Many of us living with the diagnosis and our loved ones would describe being concerned when facing a hospital admission. Yet up to half of all acute UK hospital beds are occupied by a person living with dementia at any one time, typically for a condition unrelated to their dementia. However, people living with a dementia are highly vulnerable and within the hospital setting, and their health can occasionally be significantly and suddenly worsened during an admission. Change is needed to improve the care for people living with dementia during an acute hospital admission. The care provided to inpatients living with dementia in acute hospitals is hugely variable. These experiences reflect the lack of appropriate staff training and therefore understanding the ways in which an organisation can take priority over the needs of patients. As always on these occasions, we have a panel to help us with this webinar, and they will introduce themselves shortly. I would just remind you that these webinars are designed, delivered, are put together by people living with a diagnosis, but we rely on you for your comments and for your suggestions for future webinars, which you can do in the chat boxes. If you put your hand up, we can't respond if you have any questions, but if you put a question in the chat box or the Q&A box, then we'll get around to it if we possibly can. We can't always answer personal questions, but we could probably signpost you if that's possible. So what I'm going to do is hand you over to the panel, the first member of the panel, who's Keith Oliver, an ambassador for the Alzheimer's Society, and I say a colleague of mine, and held in great esteem. He will be followed by Professor Katie Featherstone, who has great experience, and I've worked with Katie on a couple of projects as regards hospital admissions. And finally, Joy Watson, who's also a member, Dr. Joy Watson, who's also a member of the Three Nations Steering Group. So that's enough from me, and I think I'll start with Keith. Good morning, Keith.
Good morning, Nigel. Thank you for that introduction, and welcome everyone to this webinar. It's lovely to be with you this morning. So just to sort of set the scene for what I'm going to talk about for the next 10 minutes or so. I live in Canterbury with my wife, Rosemary, and during August of this year, Rosemary, after a period of significant health challenges, was admitted into an acute hospital in East Kent. And I'll talk about that with you this morning. Before embarking upon that, though, just to say something about the scene setting. Within our marriage and within our home, we do share tasks and duties. I do stuff in the home and Rosemary does stuff in the home, but it's fair to say that she does more than me. And she certainly is in charge of washing, cooking, and stuff like that. And it's always been a concern of ours that if ever Rosemary wasn't around for any reason, how would I cope? And so to be plunged into this situation of a person who's 12 years now into a diagnosis of Alzheimer's, to be on their own with family living in Egham, living in Windsor and Epsom, but one son fairly locally, the support network wasn't as close as it might have been and one would have wished it to have been. So that was always a concern at the back of our mind. And on the 23rd of August, Rosemary was admitted to hospital and she spent 8 days in the hospital. So that was an immensely challenging time for both of us. I visited every day. Fortunately, my next door neighbour gave me a lift one way, and our son or his partner picked me up and gave me a lift home. I spent every day from 2 o'clock until 6 o'clock in a geriatric ward occupied by 8 women, 5 of whom were in quite advanced or very advanced stages of dementia. My wife doesn't have dementia, even though she was over the threshold of 78 to 80 years of age, which placed her in that ward. So, what was the experience like for my wife? And in turn, what was the experience like for me? Well, one word to describe it is the word horrendous. It was horrendous for Rosemary and it was horrendous for me. Not because of what was happening at home, that worked out okay, and I'll talk about that at the end of my talk, but because of what was happening to her 24 hours a day. And the outcome of that was that I wrote a report to the Acute Hospital Trust. The motivation for this wasn't to complain. I spoke to my GP, I spoke to my consultant, both of whom encouraged me and advised me to put my concerns in writing. My background is of being a head teacher, developing young people, but also developing teachers. And then for 2 years, I was taken out of my school to be Canterbury's schools advisor for the 23 primary schools in the city. I was encouraged to join Ofsted, but said no way would I join that organisation. My role was to develop, to improve, to advise, to make better, not to cause grief, mayhem, and any kind of problems that I couldn't help resolve. So I wasn't going to go into this with a complaint. I was going to go into this wanting things to be better through the use of my expertise, my advice, my knowledge, and what I saw and heard. And this is what I put in writing that I'm going to share with you now. Following a great deal of thought and reflection alongside discussions with our GP and with you on the phone last week, today we would like to register with you some shared concerns that we have resulted from Rosemary's 8-day stay in one of your hospitals. This is not a formal complaint, and we do not at this stage envisage taking it to CQC, which was one line we're advised to take. It is our sincere wish that these concerns are read, considered, and we hope acted upon so that future care in that geriatric ward is improved. Thank you. So that's the introduction for the letter that follows. I then put a subheading, concerns. Despite being seen rapidly by a doctor after 45 minutes in triage at A&E, we then waited a further 12 hours in the waiting room. The last 2 hours where Rosemary was likely to be placed, the 2 wards where Rosemary was likely to be placed, failed to answer the phone. This caused just as much frustration to reception staff at A&E as it did to us. And from speaking to the reception staff at A&E, this was common. Later, when visiting Rosemary, the phone constantly rang and was ignored by staff walking leisurely past, and in 2 cases, studying their own personal phones. When I instructed a junior member of staff to answer, she did immediately, and it was a very significant call, personal to us, in that pathology were ringing the ward to advise staff that Rosemary's latest blood test was unsatisfactory and that she was not to be discharged. She had earlier been advised to get dressed as she was being discharged, and we awaited a wheelchair. Now, if that wheelchair had arrived more promptly, this would have caused a serious issue, largely because A, Rosemary was wrongly told she was being discharged, and B, the phone was failing to be answered. This failure to respond to patient need was absolutely constant by many, though not all, staff. Whilst we both observed and experienced some good person-centred care, the lack of continuity and evident very poor staff knowledge of both the 8 patients in the ward and what good or better geriatric care looks like was blatantly obvious. In my national role with NHS England, the Alzheimer's Society and KMPT, my wife and I, as told a number of times by staff on the ward, had a better knowledge than those working there of how to care for the elderly. Indeed, both of us on occasions advised staff of the correct actions which were then followed, which otherwise would not have been done. My wife's experience as a patient was nothing short of horrendous in that ward. No one should have been subjected to the poor level of care that she and the other patients in the ward were given. She is adamant that she does not ever wish to be placed in that kind of environment again, and I will certainly support her wishes. The placement was not appropriate, and indeed the extreme cases in the ward added to my wife's health issues, which were very high blood pressure and low sodium levels, and contributed to her stay being extended longer than it need have been. There were at least 2 serious errors she witnessed. One was an attempt to administer incorrect medication to her, and the second was a doctor talking to a patient who wasn't the one he thought she was, due to the unclear and confusing numbering of the beds and him not reading the wristband disclosing the name. There were occasions when we both were fobbed off with half-truths and blatant lies. An example being a request to a ward sister I made for a wheelchair so I could take my wife to the hospital cafe to give both my wife and I some respite from the challenging atmosphere and the noise in the ward. Staff said this was not possible to arrange. I decided to go next door to the ward adjoining the one where she was, another geriatric ward with 8 more women in, where again I spoke to the ward sister, who responded completely differently, saying that she had done this 10 minutes previously for a couple and she would do the same for us. Sure enough, within 10 minutes, a wheelchair arrived for us to use. On subsequent visits, so as not to trouble staff, I knew to collect one from the main entrance, which I did. I do have Alzheimer's disease, which was diagnosed 11 years ago, and consequently, my wife and I do know a lot about both the condition and about good care. We both feel strongly that my wife and those like her should not be placed in wards with patients whose needs are far more severe and who need greater levels of care than that ward was providing for them. We look forward to your response. I'm still waiting. I wrote that to PALS, the Patient and Liaison Service, and in fairness to them, they did ring me once and said that they'd contacted the ward on the 10th of October. They were awaiting a response from the ward as well, from the hospital. I then spoke to them again on the 14th of November, and they were surprised that I hadn't heard back from the hospital. So again, PALS said they would chase the ward. I still haven't heard. So that's a true story of what happened 3 months ago to both my wife and I. And that was my way of trying to make an awful situation better. I suppose some of the positive outcomes of this for us personally are that I now feel more confident, slightly more confident in looking after myself if my wife isn't around. So things like the washing, the laundry, whereby when she was in hospital, I did put the white liquid in when the coloureds were in there, but then decided to dump a load of coloured liquid on top of that. and bubbles didn't come out the door of the washing machine, and it didn't come out bleached. So I got away with that one. And since then, I've learned the lesson. I didn't burn the house down through cooking meals. I just about managed to feed myself and not starve and not cause a great deal of damage and mayhem. I would have walked to the hospital if I had to. I'd worked out how public transport would get me partway there. But I was so determined that she wasn't in that environment any longer than was absolutely necessary. And we then live in hope. We live in hope that other people, and those ladies who were in that ward, some of them are probably still in there. And some of them were visited by family members and some of them weren't. Some of them were ignored by staff constantly ignored. Some of them were, I wouldn't use the word abused readily, but I feel there was an element of certainly mental and emotional abuse within that ward. I didn't see any physical abuse, but I certainly saw quite a lot of neglect and ignoring, very little pacifying. And when pacification was put in place, the patient was much happier and much more settled. I saw people getting confused with people's names, staff. I saw staff sitting by tables, fiddling on their mobile phones. Me being a nosy so-and-so, I'd look over their shoulder and I saw what they were doing. I saw on a number of occasions phones ringing and not being answered within the ward, the corridor phone where the office was. It wasn't a great experience at all, but it could have been far better. It could have been far better. And I'm now going to hand over to Katie, who's going to do the next presentation. Thank you.
Before we do that, Keith, can I just thank you for sharing this with us? Hugely powerful. And if you look in the chat box, you'll see that there's great support and sympathy for you. Now, my view has always been that a hospital admission, like a diagnosis of dementia, it's not about the person, just about getting the diagnosis, it's about everybody around that person. And a hospital admission is exactly the same. It's not about, it's majorly about Rosemary because she was the one regarding treatment, but you're a life partner. So you're as affected by the treatment that Rosemary gets as Rosemary is herself. And I do think that sometimes hospital staff queue over that. Nothing you said to me, as shocking as it has been, is new information. And and that's not decrying your information. All I'm saying is, I hear these stories over and over and over and over again. Yeah. And it's not money that cures this. It helps. It's attitude. It's as Francis Isaac says, it's that little bit of kindness, that little bit of understanding, that little touch of dignity and humanity towards people when they're in hospital care, which goes missing. Keith, thank you very much for sharing this with us. Thank you so much. Over to you, Katie. Follow that.
Thank you so much for inviting me today. And Keith, yes, I thank you for sharing that. And I'm afraid to say it's not a story that shocks me either. But yes, we've got to change this, and together I really hope we can. So just to follow on from that, I'm just going to give you kind of almost a brief overview of some of the work we've been doing in terms of trying to establish the evidence base. I think we know a lot about people's personal stories, and they're starting to come through. And I think when I first started this research, I was hearing personal accounts of hospital care that were very shocking to me. But there seemed to be no evidence base. There was a lot of research looking at other aspects of care at home, living with dementia at home, in care homes, a massive focus on care homes and long-term care, but really nothing looking at the acute hospital setting. And that for me was something that I felt really needed to be addressed. This was kind of 7 years ago, and I attended a hospital meeting around the care of people with dementia. This is 7-8 years ago. And all I was hearing at that meeting was senior staff in the hospital talking about people with dementia as a problem and something that needed to be sorted out and that they didn't belong here. And I was sitting there thinking, well, what's going on? So I started to look into this and realized that, you know, as Nigel pointed out, people with dementia are a really significant population in our hospitals. They are the #1 population in our hospitals, yet still 7 years later, they're really considered a group that don't belong, that belong elsewhere, that shouldn't be here. But I just don't know why we have those cultures and why they continue. So one, we need the evidence base to really show what's happening so we can start to change it. We've got to start to change these cultures of care. And just to follow on from Nigel, what we know is, yes, people with dementia are one of the biggest populations in our hospitals. Often they don't need to be there. There's very risk-averse culture, which means ambulance staff, but also A&E staff, rather than treating someone in situ with maybe antibiotics or treating an infection then and there and sending someone home, they tend, because someone has a diagnosis of dementia, are very risk averse and admit the person. But also there are a lot of people living with dementia that when they're in hospital, they need to be there. So they need to be there for treating a fracture, a more serious infection, those sorts of things. So they need to be there and they need to receive high quality care. Because these conditions are so treatable, this population, you know, people with dementia should be going home. But this is where the problem is. We know people with dementia, and this is over a decade, 2 decades of inquiries and reports that tell us again and again, people living with dementia have a really high risk of poor outcomes in this setting. And if we see 2 people who are admitted for the same condition, let's say they're both admitted for a fracture, the person living with dementia is at twice the risk of dying as somebody who is not living with dementia. That's a really, really shocking finding. So really high risk of dying in the hospital, but also if they survive in the hospital setting, there are really real risk of deterioration in that setting. Now, we've known this for a long time. We've known about these systemic inequalities for a long time from lots of reports and inquiries. So in terms of research, our question 7 years ago was, what is it about the cultures of care? What is it about these hospital settings that are really having these poor impacts on people living with dementia? So our focus has been looking at cultures of care and looking at bedside care in particular, the organisation and delivery of care at the bedside, the organisation of care in wards, to think about what is it about this everyday care that is really contributing to these really poor experiences and poor outcomes, as Keith identified. This is systemic across the acute hospital system. So my team and I, we've got funding from the Department of Health and Social Care via NIHR for a number of studies to really collect some really high quality data looking at cultures of care. So my team and I have been in hospital wards. I've been in wards for over a year across England and Wales. It's just me and my notebook, just shadowing staff, talking to them about what's happening, but also talking to people living with dementia and their care partners and families during an admission to talk about their experiences and to find out what's happening. And if we can understand the cultures of care, we can start to think about how we can unpack that and try and do something different and support staff and hospitals of doing something different. So I'll just tell you a bit about one of our recent findings. Is that okay, Nigel? If I focus on one study? Yeah. So in the summer, we had our recent report on continence care published. So we started the first study looking at kind of a broader what's happening at the bedside. But during that first study, we identified, or rather I was just in the ward, just seeing everybody is doing continence care. It seems such a fundamental and important aspect of everyday care, but nobody was talking about it. It was very silenced work, and it's something we thought, actually, that seems really, really important to look at. So we did one piece of research just focusing on exploring continence care, and just to give a really detailed look at actually what is going on at the bedside and how that might really be creating some poor outcomes for people who are living with dementia. By exploring continence care, what we identified is what we refer to as pad cultures. We found continence pads used routinely for all people living with dementia. This is across wards in England and Wales, used routinely for all people who are admitted, regardless of their continence or their independence. This is highly problematic. So staff and hospitals were saying that this was used as a precautionary strategy to support the person, to prevent accidents or leaks. However, these are not discrete continence pads. These are very large, very visible, extremely large pads held in place by net knickers or kind of mesh surrounds. So highly visible on the person. It also means you can't wear your ordinary clothes. It means you have to wear a hospital gown. Again, depersonalizing you and who you are, and you're just wearing, basically a uniform in the hospital. Once you're placed in a large continence pad and you're wearing a gown, many staff coming to your bedside assume incontinence in the person. They assume the person has less abilities, less functionality. So once that person is placed in a pad, that has significant consequences for the person. We found that person had less access to the toilets, was less able to and less supported to walk to the bathroom and back, and was assumed to have a more severe form of dementia by staff, and assumed not to have independence. So a lot of that kind of just making a lot of assumptions about the individual. We also found that the person was encouraged to and expected to remain in bed or at the bedside, and to not only wear the pad, but to use the pad. And of course, that is very distressing for the person and very distressing as a finding. I think we found that very, very disturbing. What that does is, one, it reduced continence care, which should be about supporting dignity, to a procedure that was about checking and replacing the person's pad rather than supporting their continence and independence. The intimate care that replacing pads involves was also highly distressing for people. As you can imagine, it's very intimate care work. It was very distressing for people. And unfortunately, what we found is that intimate care that staff carried out was very silenced. So people weren't really prepared for that detail of intimate care. Rather than seeing that distress in the person, staff typically saw this as a feature of their dementia and dismissed it. This could create, as you can imagine, an awful lot of distress in the person. And we saw these patterns again and again, really, really distressing. What I'd like to emphasize here is this is about ward cultures. It's not about individual staff. We found actually that staff were also very distressed in this work as well. They wanted to give high quality continence care. They wanted to support independence, but they felt very strongly that they weren't allowed to deliver the high quality care they wanted to, that actually this was an expectation. This level of care and this type of care was an expectation of the ward, of the hospital, and that continence care had very little status and was very invisible. So I think for me, it was about the institutions, one, not recognizing that continence care is the foundation of high quality, dignified care, and really just putting the systems at the forefront rather than seeing the person and the need. I'd also like to add here that this had longer term consequences for people. So we'd find that people were going into hospital continent. Because they were having PADs, they were seen as one, less independent, less able. That really had an impact on rehabilitation. So there were far fewer opportunities for that person to rehabilitate during their acute admission. This could lead to that rapid deterioration in the person, that kind of expectations just fulfilled that sense of the person must remain in bed. So people lost a lot of muscle tone and skills during those admissions. So really hard to recover from. We also found that the use of PADs meant that they were highly likely to then be classified as incontinent and to lose those skills. So that could have really fundamental consequences of the person, in that once someone is classified as incontinent, their ability to go home and be independent and live in their own home again becomes very diminished. It becomes an issue for the multidisciplinary team, and that becomes something that becomes a key question in terms of independence and ability to go home. So it's got some fundamental, it seems like one small aspect of everyday care in hospitals, but it has such incredibly powerful and negative consequences for people who live with dementia. So in short, we've got to change this, and I hope together that we can. And I'd love to work with you all to see if we can make some change. And I think it seems something that actually we could change, and we could change those cultures in wards. So I want to work with you guys to think about how we might do that in some piloting. We're working with one hospital at the moment to do a bit of work on that, but a bigger program of change, because this is an area that is having significant consequences on people who live with dementia, and we have to change it now. Thank you.
Katie, I mean, thank you very much for that shocking and truthful indication, because all the things you said I've experienced myself as an individual, but also as working as part of certain projects within Wales. We've actually heard nurses say, "I'm sorry, we don't have commodes in this hospital," when there was two in the 4-bed next to the lady I was talking to. Sometimes it's too much trouble. I get it. People are overworked, and they will take shortcuts. But at the end of the day, it's not just the incontinence. It's just part of it.
Yeah.
I mean, if people get confused while in hospital, the chances of the chemical deterrent as opposed to distraction is fairly high. I was threatened on several occasions when I was in hospital, not because I was wandering or disruptive, but because I wouldn't stay in bed.
Yeah.
And I don't. I mean, in my normal life, when if I'm ill, I'll stay in bed. But if I'm okay, I was there for observation. So I taken a little wander, and they said, "Oh, well, we can give you things to make you sleep if you want." And I said, "No, thank you." So the reason I'm asking is this: do you think that one of the barriers to people becoming more dementia friendly, for want of a better word, is that organizational needs take precedence over patients' needs sometimes?
Absolutely. And I think so my book Wandering the Wards, I wrote a couple of years ago, and that was just something that I wrote in lockdown, just to try and get I had so much I needed to say. It needed a book, which is, it's free to download from Amazon, so anyone can access the book for free. But in that book, I went back to looking at the research that been done in hospitals and asylums back in the 1950s in America. So some classic work by sociologists in America, looking at institutional care back in the 1940s, 50s, 60s. Looking at those after I'd done my analysis of what was happening in the care of people with dementia in acute wards, in the present day, I was really struck by they were so similar. The organisation and delivery of care in our acute wards is unchanged. The routines, the timetables of care, the timetables that drive the patterns of care, bedside care in the wards, are unchanged since the 1950s or before. So they assume a patient population that we had in the 1950s, which was of working age people who'd had an operation that is now keyhole surgery and day surgery. So it's assuming a totally different population. Now, they still have a sense culturally that they're expecting that young working age population to be in the hospitals, and they're operating under the same regimes. And they're still not taking, despite all the evidence, they're still not taking it on that actually the ways in which care is organised and delivered has to totally transform to support their main population. So these kind of fraught timetables of, 7:30, everybody, lights on, everybody awake, washes, toilets, breakfast, doctor's rounds, that kind of frantic pace you find in the morning. There is actually no need for that. We could actually shift that to support the population and change it, but there seems to be such an aversion to change. It makes people feel very, very anxious. So, for example, when Keith spoke about the noise in the wards. Now, when you talk to ward staff, they go, yes, it's so noisy here, it's so fast paced, it doesn't support people living with dementia, they shouldn't be here. Now, my argument would be, why are they so noisy and fast paced? They don't have to be that way. Yeah. You can calm all that down if you really want to, if you're thinking about your patient population. So it's those things that are just seen as, this is the way it is here. These cultures that actually we have to change that thinking, that actually, yes, you might find that A&E, there are parts of A&E that will be intense and noisy and frantic, but your average acute ward does not have to have people who are marching around and marching from bedside to bedside in a fast pace, shouting, or, telephones don't have to be on loud. All those things could actually be reduced. And that would make a massive difference, I think, to everybody. Yeah. When I think about, I talk to staff, they say, I'd love to talk to people at the bedside, but we're not allowed. So there's also a real sense of those good care is often stopped as well by the cultures of care. This isn't how we do it here. So I think there is lots of ways that we can intervene, but it's absolutely about shifting those culture and those expectations. Yes. Sorry, I'm on a rant again, Nigel. You know what I'm like.
Well, I don't think there's anybody in there. Looking at the chat box, which some people are asking for your email address. I'll let you decide on that, whether you put it in the chat box.
Yes, absolutely. Yeah.
But the overwhelming support, I think, for things that you're saying, and we work closely on a number of projects, and I've always said to you, if we get it right for dementia, we get it right for everybody. Exactly. So it's not just people with dementia who are affected by all the things that you say about the busy. Yeah. It's people who are just there for pure medical reasons, who can't get proper rest in hospitals, can't get proper because they are subjected to all the things that you just described in great detail. Well, thank you, Katie. Anybody that wants to get in touch with Katie, I'm sure she'll furnish you with the email address. And absolutely. I do recommend you read Wandering the Wards. I do recommend that. Is this still free on Kindle?
Yeah, it's totally free to download on Amazon, on Kindle, on I think Google Books as well. If you don't like Amazon, then Google Books is totally free to download. Because the important thing is, this is publicly funded research. So it must be open access and available to everybody. So that's kind of my commitment to the research that we do. All our publications are open access and free to download.
Okay, that's absolutely. Thank you, Katie. I mean, it's generated a great deal of discussion on the chat boxes. Everybody's trying to do different, and everybody's trying to do better. So,
yeah, it takes all of us to make this change. We've got to do it together.
It does. Yeah. I was quite interested. We did the radio thing on your last week. When we did the Times radio thing.
Yeah.
And Henry Bonser was completely shocked by the things you had to say. And of course, he called on me, is this true? I said, well, she's not giving you the full story, you know.
Well, exactly.
You know, I mean, absolutely right. Anyway, thank you so much, Katie. Now to Joy. Joy Watson has recently come out of hospital. A week ago, Joy?
Yeah.
A week ago. I believe it or not, was joining meetings from a hospital bed.
Yeah.
So there you go. There you go.
I had the oxygen plugged in, and anyway, I suppose it would be so easy to launch straight in with the negative stuff. We all know the NHS is struggling, but with regards to dementia care in hospitals and care homes, things are changing, be it ever so slowly. I'm privileged to work alongside two lovely dementia support nurses, but their workload is unreal. Two of them cover a huge area of the Northwest. Yes, they've improved things immensely, and they are tireless in challenging the problems we face. Their involvement with people affected by dementia is crucial. It's uplifting to work alongside people who have the same determination for change. Another positive I'd like to highlight is the changing attitude of some of our trusts when it comes to dementia training for nurses, physios, and the like. I appreciate the hours given to this training is usually not adequate, but involving people with lived experience has brought about an enthusiasm among the students and their lecturers. As with all these initiatives, it's an uphill battle, but pockets of the country are getting on board, which can only be a good thing. In my view, change can't come quick enough. Sadly, I have had some bad experiences across the different departments and on the wards. Short of walking around with a tattoo on my forehead saying, I have dementia, I don't know how else I can communicate with the people who are responsible for my well-being. The idea of having an information board by one's bed is fantastic, but it's only good if the staff look at it. An issue I had with the board while I was in hospital was that it wasn't filled in for 4 days, by which time everyone was calling me by my first name. My reason for wanting them to use my chosen name was, in my opinion, valid. Due to my background, hearing my first name brought on flashbacks. I then got agitated, which the staff put down to me being awkward. Typical dementia behaviour, they concluded. So as soon as I was allowed out of bed, I rubbed out the name from the board and also Tipp-Ex'd it out from my notes. I could go into detail of other issues I experienced, but that only serves to relive what was a traumatic time. I'm happy to share my encounters if people would find it helpful, but I'm aware that people may be nervous about a hospital stay anyway. One way forward for us is to engage with the powers that be. There are issues about staffing numbers and the use of agency nurses. The morale, as we know, is very low. My experiences have been similar to Keith's. It can be very frightening when you can't express your needs. It's more exasperating when the people who are supposed to be caring for you know little or nothing about dementia. That's my story. I'm happy to share some of the problems I had.
Thank you for sharing with us. And I'm going to ask you one question, and I guess I know the answer, but I'm going to ask you anyway, because other people don't. Do you think the way you were treated had an impact on your treatment? In other words, was what you were there for more difficult because of the way you were treated?
Oh, without doubt, yes. Yeah. The impact it was having on my physical ailment was just as bad as the effects I was having from not being listened to and being, like Keith said, just ignored.
You see, we keep on hearing these extremely powerful stories from people, and I can mirror everything you say, not to that extent, because I've never been in for a long period of time. But when I went in, I felt completely dehumanized until I suddenly realized that, you know, people just didn't understand me, didn't understand dementia. I mean, I was having some hospital treatment a fortnight ago, and I was in a cubicle getting the treatment, and the nurse said, "Oh, you know that big chap in like cubicle 2? That was me. I hope he don't kick off. He's got dementia." Kick off, she used the word she used, and I sort of put my head around the curtain and said, "If I kick off, you'll know all about it." And she shut the curtains. Now, the point is, Joy, is that they saw my dementia before they saw the reason I was there.
Sadly, that's quite often the case. And it's not just on the wards, it's in the departments as well. They've got preconceived ideas, and not everyone, I will emphasize that, but if they even read your notes and realize that you are living with dementia, their attitude towards you is different somehow.
Okay, yeah. We've got a bit of time left, so I'm going to go around everybody individually now. Let's get and just ask briefly, and I'll start with Keith, if I may. If you were given the opportunity to have a quick fix, what would be top of your list, Keith, from your experiences?
Yeah, thanks, Nigel. And that was I can't thank you enough, Joy and Katie, for what you said in your presentations. My mind was going through, particularly when Katie was speaking, back to the days of the National Dementia Action Alliance and the hospitals charter that I and colleagues on the board for the National Dementia Action Alliance formulated. I can't remember when it was. It would be around about 2016, something like that. And it was a really good piece of work. And it did make a difference. But so often, these are like throwing stones into a pool and the ripples go outwards and then they disappear. And while those ripples are spreading outwards, you celebrate it and you want to try and keep them rippling outwards. And I think we need something like that, really. Again, we need something that is going to give hospitals a wake-up call and that is going to identify good practice, celebrate the good practice, and shame those who aren't following the good practice into action. And that to me would bring about positive change.
Brilliant, Keith. There's a question here from Annie Mitchell, which you may want to deal with. Is there any advice we can give to people if their family members are admitted into hospital?
Wow, that is a hard one, isn't it? I think to spend as much time there as you can with your loved one is important, because you will give the care and the support and the compassion that the staff either aren't able to give or you know, it's not happening. That would be my first piece of advice. And to speak to those who are charged with looking after your loved one, to do your best to ensure that they are caring for them, and that you're not being fobbed off, or you're not being lied to, or you're not being ignored. That would be my best advice, because that's what I tried to do, and to an extent succeeded with. But you know, it's never easy.
Katie,
can I just add to that as well? Thanks, Nigel. Sorry.
Go on.
Yeah. You know, I get asked an awful lot about what advice to give to care partners and families and people with dementia in hospitals. And there's so much I can give you. And I was wondering is actually maybe that's something we could co-produce, Nigel and all, Three Nations Group, because I think there's a massive need there's some really quick wins that you can make to make sure that your voice is heard and you're visible. And there's some really important legal stuff as well. So I think maybe we could, from this meeting, co-produce something that would be a really helpful and easy to just some quick wins for people that actually could really improve their experiences of care. So, yes. But in terms of another quick win, what I want to see is wards without pads. You know, if a continence pad is being used, it's because somebody has been fully assessed, whoever they are, whether they have dementia or not, whether they're living with dementia or not, that they are assessed in terms of their continence, and they only have a continence pad if they absolutely need one. I want to see no pads. So that's one of my missions. The other one is looking at restraint. There's a huge amount of restraint, and that's the current study we're moving on to now, is looking at the use of restraint in the care of people with dementia, because we think that's a bigger issue and is absolutely invisible in any policy or practice recommendations, but we know it happens. So yes. Again, that needs to change.
Yeah, I mean, restraint can be moving a bed so that people can't get out of it.
Yeah, exactly.
Taking somebody's walking aid away from them so they can't get out of bed and walk independently.
Yeah, exactly. It's like, Nigel, you being told to you know, get back to bed rather than walk, or you know, have some you know, some high level medication just because you're walking around. That's the kind of restraint I'm talking about. It's insidious. It's part of everyday culture. It's what we do here. That's got to change. So again, we're trying to deliver the evidence base to show this is what's happening, and then hopefully we can use that to affect some change.
Were there any examples of good practice you'd like to share with us that you saw during your?
Do you know, we saw lots of amazing practice from individuals. There are lots of amazing staff really trying to give high level care. And I think the thing that surprised us most is that when we saw those individuals, and honestly, sometimes when I see it, it actually makes me quite emotional, because it's I see so much of ordinary care, which is distressing, that when I see great practice, I have a little moment and I celebrate it. And I always say to people, you know, I love that. But quite often what you find is that the culture overwhelms. And that, you know, for example, I've seen an amazing member of staff with, you know, a bay of people living with dementia, really talking to them, listening to them, having a nice afternoon together. But every senior member of staff that passed that bay said, "Oh, is nobody working today? Oh, what are you doing all out of bed? Oh, what, you know, aren't you you know, aren't we all working today? So senior staff would come in and actually challenge that. And once a person who's doing really great care, really humane care, is told off by a senior member of staff, a matron, a sister, a senior doctor, they'll never do it again.
Yeah.
So that's what I mean about culture, is you see amazing stuff, but actually the institutional power gravitates to, that's not what we do here. So we've got to shift that bigger culture.
Yeah. How about you, Joy? You've recently come up. What changes do you like to make for quick wins? Or
I think it's trying to convey the basics. I mean, the thing that always comes to my mind is if we can help people understand that it's not just the physical needs that need to be addressed, but what comes to mind is in the Dementia Friends sessions where it's highlighted that the person with dementia won't remember, and this happened to me many times on the ward. I couldn't remember. Nurses came to me and said, you know, why are you on oxygen? I said, I don't know. Well, you must know. And then the same nurse came and said, why is your cannula on the floor? I said, I don't know. She said, well, you must have taken it out. And you can't believe how distressing that was. The next day I took it up with my husband and he said, no, you didn't take it out. It hadn't been checked for days and your arm and hand were swelling up so much they had to get it out quickly. It's just things that we can't remember the facts, but we do remember the feelings we are left with.
that's right. That's
Yeah.
absolutely right.
And that if we can get that across.
And it's the soft skills which are so important, isn't it? It's the soft skills, kindness, compassion, and everything else.
Yeah.
Well,
Humanity of care has to be at the heart.
Absolutely. We're quickly running out of time. May I thank all the participants. It's been a brilliant webinar. Thank everybody that's contributed, and thank everybody that's turned up today. Just a little mention on our next webinar is a fortnight today, and James will put the subject matter in a second. James, would you stick with the theme for the next webinar? There it is. You find it in the chat room, so I will have to say it. Can I just say these webinars rely on you? And since we've been doing them, we've had 91,206 interactions with people since April 2020. 91,206. Fantastic. Thank you so much for all the for your support during these years since we've been running them. And we look forward to hitting the 100,000 before April. So thank you very much, and good afternoon to you all. Could the panelists stay on to everybody, the rest of you? Thank you so much and have a great day. We'll see you soon.
Thank you.